The topic of this video lecture is diagnosis of the allergic disorders, medical history. Obtaining an accurate medical history is crucial in modern medicine as it forms the foundation for a comprehensive approach. Together with the clinical examination, it guides the initial impression, potential diagnosis, necessary investigations, and management plan for the patient. Mass screening for potential allergen without knowledge of the nature of this reaction is meaningless. Therefore, allergologists need to give special importance to the patient's medical history. Additionally, this detailed history can extract crucial information that contributes to the effective management of patients. When conducted accurately, the clinician's efforts are rewarded with positive outcomes and the satisfaction of the patient. The approach is similar to the standard medical history and should follow the logical sequence: chief complaints, history of present illness, past medical history, family history, and review of systems, physical examination, in vivo and in vitro testing. History taking is one of the most important diagnostic tools in medicine. Tasks of the allergological anamnesis are establishing hereditary predisposition to allergic diseases, determination of the presumptive spectrum of sensitization significant in the development of this pathology, identification of the effect of therapy, formulation of preliminary diagnosis. During the consultation, one should focus on addressing the key questions. Is the presenting complaints consistent with an allergic or allergic-like disorder? What are the underlying mechanisms for the reactions? How severe are the reactions? Is there a consistent identifiable trigger to the reactions? Do cofactors play a role? Consider other relevant information. Most importantly, the practitioner needs to start with the patient's complaint rather than what they think they are allergic to. The patient's chief complaint is a starting point and should be in the form of symptoms rather than a specific diagnosis. In obtaining the history of the present illness, it's often best to begin with more open-ended questions, such as when was your first complaint, rather than simply asking when did the allergies begin. The patient's chief complaint is a starting point and they should be in the form of symptoms rather than a specific diagnosis. Once a reaction of immunological nature is suspected, the focus should turn towards the mechanism of the reaction. Reactions can be divided into IgE-mediated or type 1 or non-IgE-mediated type 2, 2, 4 and eosinophilic diseases. IgE-mediated reactions are caused by mast cell degranulation and occur soon after, maximum up to 2 hours, allergen exposure. Correctly diagnosing the nature of the reaction has significant implications on subsequent management. Serum and skin specific IgE testings are only suitable for the investigation of IgE-mediated reactions and have no roles in other type of hypersensitivities. The hallmark symptoms of IgE-mediated reaction include sneezing, pruritus, urticaria, angioedema, bronchospasm, hypotension, tachycardia, and anaphylaxis. Establishing a link between a potential trigger and the patient's reactions is an essential part in the allergy history. The clinician should question whether the culprit could consistently reproduce the symptoms within a similar time frame. For example, a patient with true peanut allergy will consistently develop an immediate systemic reaction when peanut is ingested. On the contrary, the lack of symptoms and temporal consistency could steer away from an allergy diagnosis. Equally, an IgE-mediated reaction to food is highly unlikely if the patient has nocturnal symptoms or symptoms feel thinning in the morning. questions that could be useful in establishing or disproving a potential trigger. Were symptoms always associated with the same culprit? Can symptoms occur without the culprit? Was there any episodes when a reaction did not occur despite the definitive presence of the culprit? Is the temporal association between exposure to culprit and reaction constant? Patients with salicylate intolerance may develop upper respiratory symptoms and/or bronchospasm, asthma, salicylate intolerance, and nasal polyps, same tears triad, in response to non-steroidal anti-inflammatory drugs and aspirin. These drugs may also lower the threshold of other allergic diseases without evidence of same-star triad. Exercise-induced allergy or food-dependent exercise-induced anaphylaxis should be considered when a patient's symptoms are clearly associated with the presence of cofactors. The connection between symptoms and physical factors such as pressure, change in temperature, solar exposure, and even contact with water are well described in specific disorders such as symptomatic dermatographism, cholinergic cold, solar urticaria, respectively. A detailed interrogation of these cofactors will allow the clinician to differentiate rare diagnoses from chronic idiopathic diseases. Disease progression and severity. Progression of clinical disease is evidenced by an increased frequency, duration, severity of symptoms, or needed for increased medication requirement. For symptom control or delay in response to the same medications as compared to previous episodes are an important part of clinical history taking. On detailed history taking, majority of the patients will confirm that their allergies have progressed with time and the rate of progression will vary between individual patients. Classification of the severity of IgE-mediated allergic reaction. Grade 1. Generalized urticaria, itching, malaise, anxiety. Grade 2. Any of the above plus 2 or more of the following: angioedema, chest constriction, nausea, vomiting, diarrhea, abdominal pain, dizziness. Grade 3. Any of the above plus 2 or more of the following: dyspnoea, wheezing, stridor, dysarthria, hoarseness, weakness, confusion, feeling of impending disaster. Grade 4. Any of the above plus 2 or more of the following: fall in blood pressure, collapse, loss of consciousness, incontinence, cyanosis. Individual rate of progression may vary. For example, one may need 20 years to move from GINA 2 to GINA 4, while another could be as short as 2 years. It's important that these two types of patients are managed differently, with the latter requiring a more aggressive approach. Recollection of factors associated with symptom development such as age of onset, suspected cause, specific situations or circumstances, geographical location where symptoms occur, seasonal pattern, and response to a prior therapy may all be helpful. Since most patients present with recurrent or chronic symptoms with periodic exacerbations, data should be gathered on the frequency of recurrence, average duration of symptoms or exacerbations, and relationship to specific activities, places, exposures, eating, infections, emotions, menstrual period, time of day or season. Respiratory symptoms limited to or exacerbated during a particular time of the year strongly point to seasonal pollen allergy. Symptoms related to eating a particular food when it's commercially prepared but not when it's prepared at home may be caused by a food additive or by a hidden food allergen. The use of air conditioning, detergents, and fabric softener, and the presence of carpet, pets, or other animals in the home or work environment may all be important depending on the patient. Patient evaluation is a diagnostic process where historical information will often determine clues that are sought during the examination. No patient should have every test. Tests are chosen based on the patient's complaint history and physical findings. Evaluation may include measurement of the peak expiratory flow rate, spirometry, tympanometry, and flexible renal laryngoscopic examination by those experienced in the procedure, as well as various radiographic studies, manometry, and other. Some findings that may be important include the following. For eyes, excessive lacrimation, erythema of the bulbar conjunctiva, dermatitis of the eyelids, nose, turbinate edema and pale polyps, nasal septal deviation or perforation, chest, deformity, audible wheezing, abnormal sounds by auscultation, chest wall tenderness, abdomen, tenderness, distension or mass, neurologic, weakness, impaired cognition or thought process, including difficulty in recall or understanding their disease, skin, rashes, description and distribution, dermatographism, infection. Urticaria is well demarcated, raised and erythematous with a pale center, and is often associated with intense itching. It may occur with or without the presence of angioedema. It's important to understand that urticaria is not diagnostic of type 1 hypersensitivity and may also be seen in a number of non-allergic disorders. Individual lesions of simple urticaria usually last for less 24 hours with complete resolution. In contrast, urticarial vasculitis is painful, burning, and on resolution usually leaves brightening, scarring, and or hyperpigmentation. According to the European Association of Allergology and Clinical Immunology, urticaria can be categorized into acute, less than 6 weeks, or chronic, more than 6 weeks. Recurrent episodes lasting for more than 6 weeks are unlikely to be caused by allergy and should prompt the clinician to search for other physical, inflammatory, or idiopathic causes of urticaria. Urticaria may occur on any cutaneous surface, determining whether it is localized or systemic could be helpful, especially in the case of drug allergy, insect venom allergy, and oral allergy syndrome. Cholinergic urticaria, which is a type of physical urticaria, mainly occurs under the armpits, groins, and lower limbs. Rarely, urticaria may be associated with periodic fever syndrome. Angioedema refers to the swelling of deep tissues that affects the junction between the mucous membranes and the skin. It's characterized by acute and non-persistent swelling. However, once it develops, angioedema may take several days to resolve. It's crucial to determine the specific areas affected by angioedema. Swellings on the face and lips, also visually noticeable, typically do not pose life-threatening consequences. On the other hand, swelling in the oropharyngeal region can potentially compromise the airway. Angioedema is detected at tense, usually pale edema, usually with the absence of itching, erythema, and pitching when pressed. Symptoms of allergic rhinoconjunctivitis include lacrimation, itching in the eyes and eyelids, sneezing, coughing, chronic nasal obstruction, rhinorrhea, and the possible findings of injected sclera and dark circles under the eyes. Allergic phase. The back of the throat and larynx may have a cobblestone appearance due to postnasal edema. Atopic asthma. Patients may cough or have difficulty breathing with shortness of breath and chest tightness. There may be wheezing in the lungs, but this may be absent in patients with mild asthma. In patients with severe asthma, wheezing may also be absent because of insufficient air supply to the lungs. Cyanosis of the lips and fingers may be seen in severe asthma and hypoxemia. Anaphylaxis. Skin redness, fever, and tachycardia are usually the first symptoms of anaphylaxis. Patients may experience urticaria and or angioedema, and laryngeal edema may lead to airway obstruction. Auscultation rounds in the lungs may be detected. Impaired consciousness is possible. Anaphylaxis develops rapidly, usually reaching peak severity within 5 to 30 minutes, and may rarely last for several days. Thank you for your attention.